Hey, Ken just texted me and said he's having a computer issue. So I think what we'll do is wait for him to come on and he can call uh, start the roster, and then we'll do the minutes at that point. But I want to welcome everybody. I'm Dave Baldorf, Executive Director of the Association of Counties. Thanks for everybody's time. Appreciate it. We've got a really good board meeting lined up today, and look forward to our conversation a little bit later, talking about legislation. And then, of course, Dr. Box, the State Health Commissioner, is going to be on the line with us. She's going to come on about 11:30. But we're really fortunate to have Matt Chase with us. Matt is the Executive Director of the National Association of Counties, and Kent Ward is our liaison. He's our board member to the NACo board. So I'm going to start off the NACo portion by letting Kent Ward say a few things.
Thank you, Dave. It took me a while to find the mute button. I've known Matt Chase, there he is, since 2012, when I first met him at Pittsburgh at the annual conference. Matt became our executive director in 2012. He came to us from the National Association of Development Organizations, or NATO. And Matt's responsible for the overall management of the association, which has over 3,000 counties throughout the country. He's a graduate of Hardwick University in New York and holds a master's in political management at George Washington University in Washington, D.C. Matt was raised in upstate New York, where his stepfather was the Washington County District Attorney and judge. So, Matt, I think I will turn it over to you now.
Great. Well, good morning, all. It's great to be joining with you. Thank you, Kenton, and thank you to David for the opportunity to join you today. I'll make a couple of remarks, and hopefully we can have more of a conversation. So first, I just want to thank you all for your public service. We realize serving during COVID is probably not what you signed up for, and a lot of the demands facing your communities obviously are kind of unprecedented. So thank you all for your public service. What I was asked to talk to today is what's going on with Congress and the White House as far as COVID relief and some of the other priorities, and I'll dive into it. So first of all, right now, in about 50 minutes, the House Committee on Oversight will be marking up a massive proposal for state and local government aid. The president put forth a $1.9 trillion rescue package called the American Rescue Plan. And in that plan is a proposed $350 billion for state and local governments. A huge amount of money, a massive amount of money. And within that would be about $65 billion for counties. So those of you that worked on the CARES Act back last year, where there was money that flowed directly to certain counties above 500,000, and then those of you below worked with the state, this proposal would actually send the money directly from the federal treasury to counties, bypassing the governors and the states. For NACo, what our focus has been is not the specific dollar amount. You know, we're not championing the 350 billion or the 1.9 trillion. What we're trying to really focus on is if Congress is going to appropriate this money, which they're going to, from the looks of it, making sure that counties are respected and that your roles and responsibilities on the ground are understood. And as they work on the formula to split the money between states, cities, counties, other municipalities, that they understand the valuable role that you all play. So what NACo has really focused on is the state and local government split, where we got 60% to the states, 40% to locals. And then of the money that's flowing to locals, making sure that, quote, we get our fair share. So when we started the process last summer, cities were going to get about 69% of the money, counties were going to get 17%, and the governor would get to determine the remaining portion. Where we are today is a 50-50 split between counties and then non-county municipalities. So your cities, towns, and other local governments. For Indiana counties, this plan would actually give you about $1.3 billion. Almost an unfathomable amount of money, quite honestly. And it's something you should probably prepare for. It's not guaranteed that it'll pass Congress, but it is looking like the House Democrats have enough votes in the House, and the Senate will probably be a 50-50 vote with the vice president casting the deciding vote. So the purpose of this money is to make sure that you can continue to employ your employees. Across the country, county budgets are all over the board based on what your local tax revenue is. So in the states where counties rely on sales tax or income tax, their budgets have been severely harmed. Those of you like in Indiana that are more probably property tax based, your budgets are probably holding on or in some cases doing okay. You can also use the money to help those in your communities, whether it's small businesses or nonprofits or others who have really been harmed by COVID, particularly probably your restaurants, your tourism industry, and others. Under the bill, you actually don't have to take the money. So it'll be your option whether you want to accept the money or not. Some counties may choose not to, but we wanted to fight at least to give you that opportunity to use it. We're also seeing, based on what happened in the last year, that a lot of counties used what we call their CARES Act money for infrastructure, for broadband in particular, for economic recovery, and to help kind of your most vulnerable. This package that Congress is working on has a lot more that really impacts county governments, from tax credits to reimburse you for employees that maybe take family medical leave or are out on disability due to COVID. We were able to get a provision in there that your Senator Braun, actually was a champion of, which would allow for your jail inmates to start charging Medicaid, if they're eligible for Medicaid, 30 days prior to release. So obviously a major expense for counties is healthcare costs for your jail inmates. And we have been working for years to change federal policy. Under current federal policy, if you're under Medicare, Medicaid, CHIP for your juveniles, or even veterans, you lose your federal benefits at arrest, not post-adjudication. So you literally lose your federal benefits before you've had due process. And we've been arguing for years that you shouldn't lose your benefits until you've had due process. Now, if you're convicted or you plea out and you're found guilty, then that's up to the state and the county to deal with that. It's no longer a federal responsibility. But this package would actually now allow you to enroll your inmates in Medicaid if they qualify, and to have federal state reimbursement for those jail healthcare costs. We have been talking a lot to members of Congress about states like Indiana that have been hit by the opioid crisis, and what a jail inmate who has Hep C or HIV, just the amazing cost that they incur for the county. So we're making headway there. But David, maybe if I stop there and have more of a discussion, listen a little bit and hear what your priorities are and kind of what you would like me to focus on.
Yeah. Thanks, Matt, and thanks for taking the time to be in on our board meeting here today. This is our first one of the year. Normally, this would be we'd be having our legislative conference this week, but of course, because of COVID, we couldn't do that. But I just want to thank Matt and his staff. They've done a tremendous job, which almost been a full calendar year, for providing information to us about all the federal programs that passed back in, starting in March and April, and just really huge benefit for county government to have Matt and his team there. And they've done such a great job continuing to lobby Congress. There's some new FEMA regulations that just came out. I know Matt and his staff had a lot to do with that, where you can get 100% reimbursement on FEMA, making sure that counties got some of the CARES Act money. That was thanks to their efforts. And it's just really been a great resource, and he's had plenty of opportunities for us to call in and ask questions. So appreciate everything he and his staff have done. Hey, Matt, on the infrastructure with COVID, Congress continues to kick meaningful infrastructure funding down the road for roads and sewers, but mainly for transportation for us. Any idea what may happen with the transportation bill because of the money they're spending on COVID?
Yes, and if I can, David, to go back to your FEMA comment, really important there, where the Biden administration did just take some action that we had been asking for a while, where two really important points. One, for your FEMA reimbursement for COVID-related expenses, they now are waiving the state and local cost share. Not only for now, but going back to last January 20th, which was the date of the national emergency. So if you have FEMA reimbursements that you've been asking for, probably through your state, going back to not this January that we just passed, but January 2020, they can now waive your local cost share. And that 100% federal match will be through September 30th of this year. They also went back to the original eligibility criteria for what is actually reimbursable, particularly around PPE and other public health mitigation. So in the last couple of months of the previous administration, they kind of narrowed what was eligible because they shifted money into the unemployment insurance program, and they now have kind of widened that back up. So if you're a county that's been asking for FEMA reimbursements, I would talk to, if you have an emergency manager or your CFO or whoever is working on those reimbursements, they should really check out that new FEMA guidance. On the infrastructure side, that is really what's next. And we expect in March that Congress and the White House are going to start serious conversations on infrastructure. The joke in Washington is every week is infrastructure week. They've been talking about it for many, many years. And it'll be a challenge to figure out how to fund it, particularly during a pandemic with tough economic conditions. But we are in there fighting, really touting the county role in our ownership of roads and bridges. In particular, we own 45% of the roads in this country and 40% of the bridges. And we really need a seat at the table, not just the state DOTs. So I would really start talking to your members of Congress about the role of counties and infrastructure. Obviously, David, and in your state association, this is a main priority, and you've done a great job at the state level. But now will be definitely a conversation at the national level.
Hey, Matt, can you also briefly mention, I know you're all having a legislative conference. Of course, it'll be virtual, but maybe explain a little bit to our members how they can participate and how they're actually can sign up for the entire county if that's an option.
Yeah, so the way we're doing registration since it's virtual is your county can register, and there's a couple of different prices. But if you are a new elected official or somebody who has never participated in a NACo conference, we're actually comping your registration and giving free registrations. So if you have new elected officials or you're a member county, but you as an individual have never participated, we're giving a free registration. We're really focused on member engagement and not as worried about the finances of the conference as much as making sure people have an opportunity. You can also buy like an unlimited pass for as many people in your county that want to participate as possible. We're focusing a lot of the content on what are new federal rules and regulations, what are some of the grant programs that are coming out, particularly COVID related. And we're doing a lot of outreach with the new White House as well as members of Congress. We have close to a 50% turnover in Congress in the last 4 years. So we have a lot of education to do of members of Congress.
What are the dates for that conference, Matt, that you're always ledge?
It's actually throughout March.
Okay.
So we're not doing like a concentrated 2 8-hour days. We're doing it from, I think, noon or 1 o'clock through 4 or 5 o'clock in different days. Everything will be recorded, so you don't have to participate live. And we will have a lot of sessions, though, that are more one-on-ones kind of thing with different federal leaders. But we are recording everything so people can watch at their own their own time.
Okay. Good deal. Any of the board members have questions for Matt? If you do, you may have to unmute yourself.
Yeah, I do. This is Larry Hessen. Matt, you indicated that a county could decline the distribution under the, excuse me just a second. Could decline the distribution under the proposed legislation. If a county does that, does the amount that would be declined stay in the state, or is it simply goes back to the federal government?
Great question. So it would actually stay at the U.S. Treasury. And one of the things, so the way the process is designed in the legislation, now it could change through the legislative process, but as it's written today, if they pass this bill, there'll be $65 billion earmarked for counties. It would be allocated based on your county. So, you know, Larry, I normally would remember your county. What county are you from?
Hendricks County.
Hendricks. So Hendricks County is estimated at $33.3 million. That's what your county allocation would be, $33.3 million. The U.S. Treasury would send you a letter at the county and say the chief elected official of the county, probably your board chair, would certify that you're willing to accept that allocation. And you would have a statement of need saying that our county could use that money. You could say to them that we don't want 33 million. We only want 15 million of the 33. You know, you don't have to take the full amount. And then it's up to you to spend it. Now, what we're proud of in the formula fight is we were able to get this where the federal money would go right from the federal government directly to the counties. Be aware there's a separate pot of money for states, towns, townships, villages, other municipalities. I don't want to confuse things, but just understand if you are a city above 50,000, you will get money directly from the federal government. If you are a city, town, or township below 50,000, that money will go to the state, and then the state would sub-allocate it down to those municipalities. We didn't want to have to deal with the state government, so we fought to have direct money from the federal government to the county. And so far, that's what Congress is planning to do for us.
Follow-up question. If money is received, is there going to be a responsibility that we report back to the feds how that money was spent?
That is still to be determined. The way the legislation is proposed, there are 4 eligibility criteria, and this is not a grant. So it's not like the typical grant. It's almost like a revenue share. And it's not completely general funds, but there are pretty broad parameters how you could use the money. The 4 criteria are to respond or to mitigate to the public health crisis, including the economic impacts. Number 2 is to cover costs that you've already incurred, both since the beginning of the pandemic and through the national emergency. So probably into the fall. And that if you lost any revenue, if you lost revenue, had delayed revenue, or if you had decreases in revenue. So you might have fewer court revenues. You may have, if you have special purpose districts for like solid waste, if your collection fees were down, if you delayed property tax collections, you could use that money to backfill. And then really anything that harms your economy. So if you had a convention visitors bureau, if you had restaurants that were suffering, you could do loan programs or grant programs to your restaurants, to your hotels. You could use it in your community. And so that's the general criteria. They're still discussing how you would report back, but as of right now, they're not looking for a dollar by dollar accounting, but the chief elected officer of the county would have to basically certify that you do the right thing.
Thank you.
Hey, Matt, can it be used for broadband development?
That's unclear. We think so. You're going to have to tie it back to COVID, but I think we're talking to the White House and Treasury about it already. And there's a pretty clear understanding that particularly kids who are distance learning, families who are remote working, it's a COVID impact, and that it should be allowed. So I can't give you a 100% answer yet, but we think it's going to be. It's just not 100% certain. That's our priority. We actually have a national broadband task force going on right now, and we just keep hammering how rural areas and other pockets are underserved. You can't even sign up for a vaccine without broadband in most places. I mean, a lot of you have volunteers and you're trying to help folks going door to door and with phone banks. But the reality is a lot of the private sector pharmacies and hospitals are using web-based sign-up systems. And so that just ties back why you need broadband.
Hey, follow-up question too. So Matt, do you have a list how much each Indiana county would receive?
Yes,
Okay.
it's on our website. I'm not a WebEx expert. I use other tools.
Okay.
I'll put it in the chat. How about here? I'll find the chat and I'm going to copy and paste it into the chat.
Okay, thanks.
So I can figure out how to send it.
I've got a question for you, Matt. So every state's a little different in how finances are managed in each county.
Correct.
As far as procedurally or technically, how far into the detail or the weeds will this money get in terms of, once it reaches the particular county, the rules behind, who decides where that money is to be allocated and that kind of detail.
Yeah, I mean, Congress will not get into that level of detail. There's no way they could figure out 3,000 counties and 38,000 municipalities. In Indiana, you have a very unique setup with your councils and your commissions. So that will really be up to how you handle it.
Good. So it'll just be a general considered miscellaneous revenue, and then it's up to the locals or maybe even state law and how that's handled.
Correct.
Okay.
We're trying to use the best parts of the CARES Act, the Treasury money that flowed to the state, and then in your case, I think some flowed down to the counties. We're trying to use the best parts of that and get rid of the worst parts. So
absolutely, yes.
I would start preparing. We all know nothing in life is free. So
yeah, that's true. That's true. And the other quick question I had is, at the moment, that money may be received, that may not necessarily be the moment in which it's needed. And so, a year from now, when we may have a revenue loss that we're anticipating, just simply banking the money and not necessarily spending it may be an option that we need. And I'm assuming that would be allowable in this legislation.
Yeah, the way the legislation is crafted today, now it's subject to change through the legislative process, but it would be available until expended. So they're not proposing a deadline. Now that may change. And it's typical Congress where the pendulum swings, where under the last bill, you had this crazy deadline of December 30th, and now they don't have a deadline. But we have talked about states like Indiana, where your revenues tend to lag the economy by 18 months. And David has talked to me repeatedly about your tax collection system and how it's not real time. And so we've been talking to Congress about that.
Thanks. Last thing, I see Dr. Box has joined us. Hey, Matt, if you can just give a final comment about the Leadership Academy. I know there's a couple people on the phone who have taken or on the call who have taken the leadership class. If you could give some final comments on that, I'd appreciate it.
Great. So a couple of years ago, NACo created the High Performance Leadership Academy in partnership with General Colin Powell and Dr. Marshall Goldsmith and others. And it really was intended as a give back to counties. There is a cost, but we have scholarships where we just feel, America's counties employ 3.6 million Americans. Over 1% of all Americans actually work for county government. And yet we felt like we didn't really have an appropriate leadership program for emerging and current leaders. And we realized people can't travel. So we helped develop this online program. Some of you are probably, as David said, I think we've had 46 people in Indiana go through it, out of the 33 counties. If you have a financial hardship and you can't afford it, we are willing to provide scholarships. This is all about trying to give people the skills to bring positive energy to your county and to your community. That our view is, I've got 2 of my executive committee members who have been facing death threats. We had one of our officers had 36 militias surround his house on Thanksgiving Day with AR-15s. Kids being threatened, public health staff being threatened, and we're trying to bring positivity and give people new skills to lead, bring people together and lead people. So we just view this program as a great opportunity to train people, give them the right mindset, realizing, life does hit you in the face sometimes, but we just view it as a really important program. And if you're interested, let us know. There's a cost, but again, if you have a financial hardship, we'll waive the cost and we'll figure out how to get people in the program.
All right. Well, great. Thanks, Matt. You're more than welcome to stay on the line. I'm sure you may have other calls to get to. Again, appreciate your leadership. I can't imagine how difficult it is to lead counties throughout the country with the different varying, challenges they face in the political climate that can be pretty broad. So you do a great job. We appreciate it.
No, thank you. It's the public servants that, as mentioned in my bio, my father was an elected official, and I know what it's like to live with you and to go to the grocery store and walk in your communities and realize it's a tough job. So thank you for your public service.
Thanks, Matt.
So, have a great day.
Thanks.
Thank you.
Hey, I'm just going to check real quick. Did Ken Powell get on yet? Are you on, Ken? No? Okay, well, I'm going to go ahead and introduce our next guest. And speaking of positivity that Matt just mentioned, Dr. Christina Box has done a tremendous job leading the state with Governor Holcomb. And of course, she's at the State Department of Health. And her positivity for me has been very comforting the past 12 months. The weekly, we'll start off maybe daily and then switch to weekly updates that we receive from the State Department of Health, I think provide a lot of assurance to the citizens of Indiana. And I can't imagine the personal sacrifice that she's made to lead the State Department of Health in Indiana through this pandemic. So Dr. Box, thank you for joining us. And I'm going to turn it over to you.
Thank you so very much. Those are kind words. I got to tell you, my team, when this pandemic slows down and everybody's been vaccinated, you'll probably find us on beaches all over the world because we all need a break. But for right now, it's all hands on deck and just an incredible team that we're blessed here, not just at the State Department of Health, but all of our agencies with the governor and his team, and then our partners all across the state with hospitals and local health departments and FQHC. So that's been really incredible. I'm going to pull up my slides here and share some slides, and then we'll leave some time at the end. Okay. So that we can, oops, wait a minute. And let me see if I can get this to share.
And I can share it here if needed, so.
Okay. If I don't get it, I may have you do it.
I think we got it there now. Yep. Now we can see your slide.
Okay. Does it take up most of the page or not?
No, it's a smaller set, but it's readable. So
can you show me? 1 second. Oh, there I see the enable editing. This is usually what my kids or the kids here at the health department help me do. Unfortunately, I'm not a technology queen. Sorry. Okay, and I should be able to change them then myself.
Yeah.
All right, everybody see that okay?
Yep.
Great. So it's really an honor to be able to be here with you today. I wanted to share just kind of where we are. This is data from yesterday, actually. And you can see we were down to 6.1% for positivity for the state. We're actually today at 5.8%. So I'm in a race with Fred Payne to see if I can get down below his 4.3% of unemployment rate, which it's going to take a little while, but I think that we could do that. We still continue to see the virus, unfortunately, take an incredible toll on the number of Hoosiers that have died from this disease. If you look at actually the 11,604 and add in those clinical deaths, you'll see that we had actually about 12,000 deaths in the state of Indiana so far. I wanted to take a moment just to talk about our deaths overall. First of all, every one of these deaths represents a tragic loss to the family, to our friends, their family members, their neighbors, there are church-going friends, and it's been incredibly frustrating to hear people kind of accuse us of wanting to inflate the numbers, honestly, to try to keep the state closed down. I wanted you to see this slide so that you could see that our average number of deaths per year is normally around 65,000 if you average those numbers out. Us seeing around 76,000, almost 77,000 for 2020, and that's a preliminary number. But really, our number of COVID deaths accounts for that real difference. When we look at who has actually been sick with COVID-19, about 1/3 of our cases are in people under the age of 30. We know that those young people are the ones that frequently get infected and then bring it home to the rest of us. About 45% have occurred between ages 30 to 60. Again, the people that are going out every day and working oftentimes and with the public. But about 23% of our cases, only about 23% have occurred in those individuals that are 60 and older. But 93% of our deaths have come from this age group. And that's important as we look at how we've started to roll this vaccine out. It was really just about a year ago right now that we were on the cusp of this pandemic. We were really, preparing for what we were hearing from China, trying to get testing up and running, working with the CDC on a daily basis, listening to what WHO was saying, and then actually ended up, I think, with our first case about March the 6th and our first death about 10 days later. At that time, we didn't really know a lot about the disease or the virus, and we really didn't have any hopes of a vaccine in the future. Fast forward to now, we've learned a tremendous amount about this virus, and most importantly, we are blessed to have 2 vaccines already up and being manufactured, the Pfizer and the Moderna vaccine. They both have received their emergency use authorization, and we are actually using them around the state. They're both called mRNA vaccines, and I'll talk just a little bit more about that in a minute. But the great news is that these vaccines have about a 94 to 95% efficacy. That may be dented a little bit by some of the variants that we are starting to see around the world. But the good news is, even with the variants, we are still seeing minimal to no hospitalizations and no deaths associated with it.
Good.
It is a 2-dose vaccine, so Pfizer has to be given every 21 days and Moderna every 28, and it doesn't have to be right on the numbers. We'd like to get it in within a 42-day window, and if we do, we're very pleased, and actually the longer time may be even a little bit better as far as bringing about immunologic response. I'm sorry, thanks, Amy. When we look at this, Pfizer's approved down to age 16, Moderna down to age 18. There are other vaccines in the pipeline. The Johnson & Johnson, as you know, just applied for their emergency use authorization. And we have a meeting expectation at the end of the month with ACIP and the CDC and what we call the VRBPAC, which is actually the individuals who look at all of this data and determine whether they have met the EUA requirements. Johnson & Johnson could eventually be the workhorse vaccine for us because it's a 1-dose vaccine. It doesn't have to be ultra low stored, or it doesn't have to be frozen. It could actually end up just in the refrigerator, which is great. And there's no reconstitution required, so we don't have to mix it with anything. So we'll wait and see when we might be able to start getting some of those doses of Johnson & Johnson out. Johnson & Johnson is what we call a virus vector vaccine, where we use another very benign virus to actually deliver that genetic material. So the Pfizer and Moderna, as I mentioned, are mRNA vaccines. These actually give our cells instructions to make a harmless piece of a spike protein, which is on the outside of this particular virus and found on the surface. And that's what helps the virus attach to our cells and then infect our cells. When we give these mRNA vaccines, the mRNA actually goes into the cytoplasm, not the nucleus of the cell, so nowhere near the DNA, but it actually causes our cells to make this particular spike protein so that then our body sees that as an adverse or abnormal protein to our body, and we make an immunologic response to that. The Johnson & Johnson, as I mentioned, is a viral vector vaccine where we actually put the genetic code in a very benign adeno, kind of a common cold causing virus, and then deliver it to the body that way. There are very few severe reactions associated with this vaccine. And the CDC's VAERS, which is the vaccine adverse effects place where you can actually tell the CDC what adverse effects have been reported, is up and running. And we get reports on that from a regular basis from around the state for anybody that has any kind of reaction. The most severe reaction has been anaphylaxis, which is an overwhelming allergic reaction, and that is about 4 to 5 times per million individuals who have received the doses. The typical patient will get arm soreness, maybe even fatigue, a low-grade fever, muscle aches, and that's normal, and that means your immune system is working. These cannot deliver any live virus, so there's no way you're getting infected from it. But that's your immune system working. And so the more you see that, the better that sign is. You can still get COVID, even though you have gotten these vaccines, just like you could get influenza after receiving your influenza vaccine. But the important thing, as I mentioned, is that you don't end up getting hospitalized or dying from this. It's really unbelievable the amount of myths that are out there and the misinformation that's surrounding these vaccines. And I just wanted to mention a few of them. We've had people say that this can give you COVID. Absolutely not. There's no COVID virus in this vaccine that's live. That people think that there's a microchip in the vaccine. I can 100% assure you that that would not be the case. We'd never do that, but also wouldn't fit through the needle anyway. The vaccine will not make you sterile. This is a favorite one to scare young adults off of taking this. And many of the anti-vaxxers use this as an excuse, especially with something like the HPV vaccine. And the vaccine doesn't alter your DNA. It doesn't go into your nucleus, which is where your DNA is, and it does not insert into the DNA in any way, shape, or form. We have been disseminating information and keeping our partners informed across the state and engaging them all throughout this pandemic. And that has been absolutely critical in our response across the state. Our partners have been overwhelmingly an important part of our response. So we have had weekly and sometimes twice a week webinars with our healthcare providers to keep them up to date on data and information that we get from the CDC and comes out in the research and literature. And we have a partnership actually with IU Research Hospital and the state, and they have actually been giving us condensation and further information that they get from the literature almost on a daily basis. And we can reach out to them with any questions or concerns that they then answer. We've been working with our local health departments. We started with twice a week webinars and we're down to once a week webinars now. We have a weekly school webinar with all of our schools. And our hospital calls early on were even things like bringing hospitals together in different parts of the state to talk about, do they have ICU beds? Do they have ventilators? Do they need testing supplies? You know, what are the needs? And then also as we go forward now, they've been probably our most important partner with regards to vaccinations. I want to say I'm on a call on a weekly basis with the American State and Territorial Health Officers from across the United States and in Region 5 here in the Midwest. And when I was talking about the number of hospitals we had engaged, and you know, we have well over 290 sites right now that are up and running. Everybody's like, well, how did you get your hospitals to do that? And your local health departments, well, did you pay them? Did the governor put out an emergency order that they had to do it? And I'm like, no, we actually asked them. So I think that the partnership has been overwhelming here in the state of Indiana, and I'm incredibly proud of the partnerships and collaboration that we've had. We've been working with our minority stakeholders from the beginning on a weekly type meeting and working to make sure that what messaging we put out and the areas that we reach, that we are actually resonating with the populations we're trying to reach. We've had a lot of cross-agency collaboration, and I give the governor a lot of credit for that because he basically has brought FSSA, Department of Homeland Security, NDOT, ISP, everybody together, along with our National Guard, working on the same page and rowing in the same direction. And that's been a big part of our success. I do want to mention that we've had EMS work with our local health departments on a portal for homebound individuals, so that our local health departments, when they have additional doses at the end of the day that are left over, we never waste a dose. But now they have the ability to go to a portal, find someone in their community that is homebound that actually has been screened and we know they can't get out to get the vaccine. They call EMS, EMS comes by and picks up the dosage and actually takes it to that homebound individual. And I credit Dr. Kaufman and Dr. Sullivan for the work on all of that they've done. We also knew that working with our older population, or as many people say, our more mature population, that we might have issues with people not having smartphones, having computers, not having an email address. So we actually worked with 211 with our area agencies on aging, IARP, and our libraries, not only to reach out to this population and get them scheduled for their vaccine and help them to understand about the vaccine and its safety and its efficacy, but also to actually do this scheduling. The libraries across the state, over 300 of them, have set up computers and have someone there to also assist. Our Guard has been absolutely critical in our partnerships. They've done reporting for us and testing with the long-term care. They've had clinical response teams to go in and assist our long-term care facilities. They have run our food banks. They have done testing and vaccination sites, and they're going to be intimately involved with our mass vaccination sites across the state. And then, of course, many counties have partnered with their local elected officials, their mayors and their county commissioners, and their local public health to really bring the state and the local elected officials and public health together. From the beginning, we knew we were going to be blessed if we could even have a vaccine to give out, but we knew that that supply would be somewhat limited. And we knew that we would need to be able to be very careful in how we allocate that vaccine, which actually could be life-saving for many individuals, both morally and ethically. So Department of Health, Dr. Weaver, who's our Chief Medical Officer, actually formulated an advisory committee from people all over the state, which include vaccinologists and immunologists and infectious disease experts, and it had clergy on it. It had individuals that were trained in ethics, local health departments, physicians, and people from all over the state, minority health, to make sure that they came together and not only looked at all the vaccine information that came out through the ACIP, which is the arm of the CDC that actually looks at all vaccines for their safety and their efficacy, but they were sure to look at it from the standpoint of, here in the state of Indiana, and we're rolling it out to certain groups. Is it appropriate for this group? Is it safe for this group? Has it been studied in this group? And then to help us to actually develop those priorities or those eligibility categories. So we prioritized phase 1A, the need to reinforce our healthcare system and to help prevent disease. So we worked in rolling this out with 55 hospitals to begin with, and they immunized not only in their county, but in other counties, healthcare workers, first responders, long-term care residents, and staff. And then 1B has always been, the plan is that we were going to protect the vulnerable by vaccinating those individuals that were at particular risk of either dying or having severe consequences and being hospitalized from COVID-19. We found that age is the #1 factor, the #1 comorbidity that increases your risk for serious illness, hospitalization, and death. And that is why we started in phase 1B with breaking it down by age, over 80, over 75, over 70, that kind of breakdown. We are now down to individuals that are 65 and older. When we get down to 60 and older, which I'm hoping will be next week, we will have actually accounted for 93% of the deaths in the state and 64% of our hospitalizations. Phase 2, when we submitted our plan to the CDC, has always been mitigating the spread by vaccinating individuals who have in-person work where they're essential, it's required, and it's difficult for them to be able to maintain that social distancing. And then phase 3 will be that general public and also our children, because at that point in time, we should have vaccine for them. We're also working to prioritize Hoosiers that have other high risk factors, including some of the highest risk factors in solid organ transplant, individuals who are undergoing dialysis, people who have sickle cell disease, those with Down syndrome, people who are actively receiving cancer treatment right now or within the past 3 months, and people who have active primary lung disease, primary lung cancer, or hematologic cancer like lymphoma, leukemia, and multiple myeloma. With the vaccine rollout, we began about December the 18th with healthcare workers. Then we added long-term care and assisted living facilities. And we partnered with a federal partnership through that with CVS and Walgreens, and that was December 28th. We started, as I mentioned, with the age-based rollout on January the 8th, and we have now actually put over 1 million doses of vaccine in individuals' arms, with about 760,000 unique individuals that have received at least their first dose. As I mentioned, over 65 is now eligible, and we are planning to continue to go down to 60 and above, 55 and above, 50 and above, and when we've reached 50 and above, by looking at Indiana's data, we will have actually covered 82% of individuals in our state that have underlying comorbidities. At this time, Indiana, as I mentioned, has over 290 sites. We will have well over 320 or so sites by mid-February where Hoosiers can receive the vaccine. It's available at hospitals. It's available at local health departments, some retail pharmacies. We rolled this out to about 44 federally qualified health clinics and community health clinics because we knew these were located in areas where socioeconomically people were oftentimes in the lower socioeconomic groups. It was difficult for them to get connection with healthcare, and also represented a higher percentage of our minority populations. Nearly 60% of the 65 plus population has actually already signed up for this vaccine. We're seeing a great response as far as these age groups and wanting to be vaccinated. We truly are in a battle still of supply and demand. The CDC has sent out over 1.2 million doses to Indiana, but more than 920,000 Hoosiers have already scheduled their first dose. 1.6 million appointments are also scheduled for first and second doses. We expect to receive in the next 2 to 3 weeks about 100,000 doses per week. The Biden administration is trying to make sure we have a better idea for about 3 weeks going forward about what our allocation will be. But we're hopeful by the end of February to early March, we may also be adding J&J vaccine, that's the Johnson & Johnson vaccine, and potentially even additional vaccines of the ones that we are already receiving. This just shows you on the top line a screenshot from our vaccine dashboard with our rshot.in.gov, and you can go there and actually find all of our sites that are available. You can sign up for your vaccine there. You can see this vaccine dashboard and see that we have administered already almost 760,000 immunizations first dose, and about 280,000 individuals are fully vaccinated at this point in time. And as I mentioned, over 1 million doses administered. This shows you the map on the left, all our vaccination sites. And when you actually hover over those sites, you can find their hours. You can find out how to actually sign up for an appointment at each of those sites throughout the state. On the right, you can see the number of doses each county has administered so far. And we also have information on our vaccine platform about how many doses have been administered to people that live in a particular county. So for instance, you see Marion County has administered a lot of doses because they have a lot of large hospitals here. But a lot of those doses are for the donut counties around them. So we also break that down for the counties so that they can see how many doses they have actually administered. The way we determined the vaccine administration site distribution is based on the site's capacity, the total county and local population. We look at the population of the individuals within the county who are currently eligible, like when we started, how many healthcare workers were there, how many first responders, how many individuals age 80 and over, and then 70 and older, and 65 and older. So for instance, Knox County has one of the oldest populations in the state, and that was taken into account as we gave vaccine. As more vaccine becomes available, our focus is going to be on primarily ensuring that we make sure underserved areas of our state are receiving vaccines in areas where we know we can reach populations most easily. To help reach our minority and our vulnerable populations, the state of Indiana has already partnered with our federally qualified health clinics and our community health centers and our community health clinics, as I mentioned, and they've done an incredible job filling appointments. And they're not just vaccinating their own patients, but their entire community, anybody that would walk up and want to schedule an appointment. This week, the federal government announced that they're going to start directly giving vaccine to the FQHCs and community health clinics. We haven't had any engagement on that, but we are happy to see that happen because, as I said, we've already had 44 of them engaged for 4 weeks. We've been meeting with our minority stakeholders from around the state for several months now to identify barriers for individuals to get vaccine, messaging needs, the work that needs to happen to approach our public awareness campaign called Our Shot Hoosiers, and making sure that we are actually engaging individuals across the state from different minorities to actually show themselves getting vaccinated, talk about why they got vaccinated, talk about how they felt afterwards, and the importance of getting vaccinated. This campaign, Our Shot Hoosiers, is running already statewide, and we'll continue to increase that across the state, especially with our minority stakeholders. In addition, we have all kinds of fact sheets and other information in multiple languages, and our website can actually be, you can click a button to get our website in many different languages so that individuals can engage that way. Despite the demand, there's still a lot of vaccine hesitancy, especially within our minority and immigrant communities. And much of this is built on that historical distrust that we know occurs because of things like the Tuskegee experiments, where we treated syphilis we didn't treat syphilis in Black men, and we just studied them. Other causes that result in mistrust of the federal government and the local government has been a big hurdle. It's a big hurdle to overcome, and we're working to address these on multiple public awareness fronts as we work across the state with our minority populations. We're focusing on that special emphasis of engaging, as I mentioned, communities of color, not only in video type social media programs, but in billboards and other areas across the street, making sure that we have publications in our barbershops, billboards in our Amish communities and other communities. We also are continuing to add material and adapt as we progress through this pandemic. And my hope is that by the fall, we'll have be in a very different place. I would like to say that our goal right now is to work within communities across the state to identify different populations that we need to be able to engage, whether that's the immigrant population, the Burmese population, the Congolese population, an African-American population, a Latino population, and make sure that we are engaging trusted individuals within those communities, educating them about the efficacy, the safety of the vaccine, why people should get the vaccine, who this vaccine has been studied in, so that they can also work then to help sign people up for the vaccine across the state. We also have, unfortunately, COVID's keeping us on our toes because we have many new mutations of this virus that are coming out. We don't look at every single mutation, but there are some of them that are called variants of concern. The one that we have here in the state is the B117 UK variant that has been identified in Indiana, is one of about 12 states. One of 34 states. We have 12 cases here in the state of Indiana. This variant changes that spike protein that I was talking about on the outside of the virus, which is what helps to allow the virus to transmit the infection more quickly to other individuals, about 1.5 times more quickly. We don't really understand right now. There's conflicting data about whether this actually causes more severe disease or increases death. We know by increasing the number of people that are infected, it will increase the number of people that get hospitalized. But is that more severe in those individuals? It's hard to say. The South African variant has been seen here in the US, but not in the state of Indiana, and it behaves much like the UK variant in that it transmits much more quickly and individuals become infected more easily. And the P1 variant from Brazil, we have at least 2 cases in the US. These variants, as Dr. Fauci said, will make a dent in our vaccine's actual efficacy, meaning how good they are at preventing infection with COVID. But the important thing is that these vaccines still work in 85+% of the population to make sure that no severe disease occurs. And in fact, as you look at them, we have not seen with these variants that individuals end up hospitalized or dying from this. So that's the key component of this. It's very similar to influenza in that in a good year, our influenza vaccine, if it hits, it covers about 40 to 60% of the strains, but it's very good at preventing hospitalizations and death. These variants really underscore the importance and the need for us to continue to practice mitigation measures and to get vaccinated when eligible, and we will continue to follow these variants and changes. I wanted to briefly mention what we've been doing with schools. We've had regular webinars with them. Recently, our community spread has come down significantly, so we have opened up and said, hey, we support all 3 of the CDC's options for quarantine. The one that we've always supported is the 14-day quarantine, which has less than a 0.1% chance for the individual to become infected after that 14 days and infect another individual. We have also supported now the 10-day quarantine that you can return on the 11th day without getting tested, as long as you're fastidious about wearing your mask, including at lunchtime. You take it off, but you have to be 8 foot or more, 6 to 8 foot socially distanced. And making sure that those individuals, if their athletics or their social activities or being in band or choir means they have to take their mask off, that they cannot do that until they're outside that 14 days and still socially distanced. The 7-day scenario, actually individuals can return on the 8th day if they actually get a test on day 5, 6, or 7. So you could actually go get the traditional PCR at any of the sites, and our turnaround time now for 90-some% of our tests is less than 48 hours. So you could have that result back, show that, and get back into school. Or we have given the school some BioNext Now cards so that they can actually do a nasal swab and an antigen test on a student that returns to school or a teacher. And we want to make sure that this is available if the schools are interested in doing this, because we know that many students are not able to get that testing done and may be really in need of and wanting to get back to school for educational and social emotional reasons. We also have changed that if an individual comes in contact within the classroom, and everybody in the classroom was masked at all times, and that individual was at least 3 foot, it used to be 6 foot, but at least 3 foot socially distanced, we have now told the schools they do not have to do contact tracing or quarantine anyone. But that is just in the classroom. That doesn't apply in the hallway, in the lunchroom, at the football practice or basketball practice. It doesn't apply in band or other places where we know that people take their masks off, are not socially distanced, and there's not as much oversight. That's it on that. So just want to give you a glimpse of the future. Indiana State Department of Health does have multiple mass vaccination clinics and sites that are planned. Some of those are with local health departments. Some of those are with hospitals. Some of those will be with the 10 mobile vans that will have one of these in each preparedness district. And those vans will be able to go out and do thousands of vaccinations within a week's period of time when we have enough vaccine to be able to do that. I think it's important to know that we are going to continue to need to be masked and socially distanced to the best of our ability for a while longer. It's going to be months before we have enough supply and doses to be able to actually get anywhere close to herd immunity, which is at minimum 70%. If you listen to Dr. Fauci, it's probably more like 80 to 85%, especially with these new variants that we're seeing. But once we get to a larger number of people that are vaccinated, then we know there are very, very small amounts of disease out there that will tremendously make it safer for us to be unmasked. We also know that individuals that are actually vaccinated oftentimes may still carry the virus around in their nasopharyngeal area and could be at risk in the future for infecting someone else, even though they may not show signs or symptoms. So that study is ongoing to see whether they're actually at risk of infecting someone. And about 5% of individuals, especially as we look at our older population, may be what we call non-responders, meaning that they may not have a good response to the vaccine immunologically and so may not be as protected as we'd like them to be. So basically 2020 has been one for the record books. 2021 is stacking up to be the same way, although fortunately we're seeing less cases and less hospitalizations and getting the vaccine into arms. And as the federal government is able to give us more supply, we are getting it out as quickly as we actually get it. So I'm happy to take any questions you might have, and I will see if I can stop sharing here.
Well, thank you. Very informative. And for our board, we do have a copy of the PowerPoint, so we'll send it out after the meeting today.
My pleasure.
Again, thank you, Dr. Box. One question we had was, even if a county, and I know you have a hard stop, so when you have to go, just let us know. We understand. When if a county health department has capacity, but you're still sending immunizations to the CVS or other non-government facilities. I guess that was one of the questions we have. Why not just send them all to the county health department if they have capacity to do the shots?
So to date, other than a couple of counties, we had a couple counties that local health department was not able to do the vaccination, and there was no hospital in that county. So we picked a pharmacy in each of those counties. Otherwise, to date, we have not given CVS or Walgreens any other vaccine at this point in time, except for what they're using for local health departments. Now, the federal government a couple weeks ago, maybe 3 weeks ago, said, hey, when we have plenty of vaccine, who would pick two? What pharmacies would you like to use to be able to get vaccine? And we said, well, when we looked at the coverage across the state, especially in our rural areas where we oftentimes have trouble with coverage, we said Walmart and Kroger. Well, lo and behold, the next week, the federal government announced that they weren't taking our vaccine and giving it to them, but they were taking these additional, in Indiana, probably about 20,000 doses and giving them to those clinics. And so in all honesty, we didn't really get any input into that part of it. We do look to have more than one site available in counties if we can, because oftentimes a particular site will have only so many days a week they work. They will have certain hours that they cover. And so we like to have other options available to people so that they can have, maybe additional hours, whether those are weekend hours or in a pharmacy, et cetera. So we've been really careful to try to distribute this. And the hard part of what the federal government is doing with taking doses that they say are not coming out of our allocation. But my argument would be, hey, if you weren't giving them to these places, you give them to us and we would get them out, right? So we understand our local health departments, our hospitals, even our FQHCs and community health clinics, they all want more vaccine. And so we are doing, every vaccine dose that we get in, we get out. We are not keeping it. And that's why right now, many of our mobile vans are sitting unused because we just don't have vaccine to give them and we've got places to give it elsewhere.
Okay. Yeah, that question was from Wayne County Commissioner Ken Powell, who's our president. So Ken, I know you joined us a little bit late, so glad to see you on.
I apologize. I lost everything on my computers, but fortunately it was a good IT department. They finally got in here and at least got me back on this program on there. Christine, I really want to thank you very much for everything that you are doing. It's you have a task that's very difficult. We're all looking for more vaccine. And David kind of asked part of my question. We're geared up with our public health side here to do in excess of 1,000 vaccines a day, but we only get, we get 600 a week from you. So we can only do 100 a day. And I agree with you, the feds are kind of messing it up when they talk about Kroger's and CVS and Walgreens. They really don't have the staff, and we're sitting here with a perfect location ready to go. And then they're splitting up the vaccine and sending it out to those places. We have a mobile unit also, as you know, and we're ready to go. It's just the feds aren't sending you enough vaccine to do that.
The good news, I heard that Dr. Fauci said he thinks by April, everybody that wants to get a vaccine is going to be able to get one. If that's going to happen, then they must be planning on sending me a whole bunch of extra doses. So, fingers crossed that's going to happen. I think Johnson & Johnson will come out. I think sometime, I doubt at the end of February, I'm hoping by early March. But we are ready and willing. We know every site has told us maximum how many doses they think they can do. My goal is to fill up the sites we have first with vaccine and open additional sites or send our mobile units out from the Department of Health if there are additional doses that we have.
We have, and I haven't had a chance to fully check this out here, but Reed Hospital has a 4-county site, was doing both the Pfizer as well as the Moderna. What happened in the scheduling, I'm not sure how this happened, make a long story short, Reed doesn't have the Moderna anymore, so they're shoving everybody to our site. We were already booked out 3 weeks on our site, and now we have all these other people coming, but we don't have any additional vaccines. So that's been a real problem here for us.
Okay, you know what? Have your vaccine team reach out to us, because if we have extra doses, we'll try to cover that. I'll tell you what happened. The hospitals came to us when we very first started. The only people giving vaccine were the hospitals. So they got both Moderna and Pfizer. And we came back and said, Pfizer is difficult enough to work. It has to be ultra low. It has to be reconstituted. We're getting our pharmacies to do that. We only want to do one type of vaccine. So we actually redistributed that Moderna vaccine from many hospitals to other places, or the hospitals gave it to their local health departments to use. So that was more of a request of the local health departments, of the hospitals, to have that redistributed, so they were only giving one vaccine.
We have reached out, and I will just say the response from the state was, well, it's pretty much our problem.
Well, I can certainly check into it, but so you're doing it for 4 counties, sir, at your local health department with Moderna?
I can't say we're doing it for all 4 counties, but we do have folks coming in from all 4 counties into our site to get Moderna. We've got Union, Wayne, Randolph, and some from Fayette that are coming up into our area. Yes. And of course, Reed has their 4 county site, which is in our fairground location.
I certainly can look at that, sir. I know it's not that we don't want to give you a vaccine. It's just a question of how much do we have. So I will definitely take a look at it myself.
Okay, thank you.
You're welcome.
That kind of leads to the next question about the distribution. You know, the larger counties are getting this transient group will come into the larger counties to get shots. And so are the distributions based on pure population or population age? How is the vaccine being distributed?
Yeah, and I mentioned that it's all broken down in my PowerPoint, but basically it depends a little bit on how much the site says they can do, right? If we have extra vaccine, we normally are offering it to local health departments first and then going elsewhere. It depends on the percentage of the population. So not only the whole population of the county, but looking at the population of those individuals, say 70 and older or 80 and older, the percentage of healthcare workers, the percentage of first responders, looking at individuals that have comorbidities now going further ahead. And we will be working with our renal dialysis units to get vaccine to them. We're working with the Down syndrome associations here in the state to send out special invitations to individuals with Down syndrome. We're working with our oncology doctors across the state and renal transplant doctors. So we know that there are certain comorbidities that, now that we are getting down to that age of 50, start to rise to be as high as just your age alone. And so we want to even that out as we are in the age categories with picking up some of these higher risk comorbidities.
Okay,
thanks. Christine, one of the things I might say that we run into here in Richmond, we have, several thousand folks that come in from the Ohio area that actually work in Richmond, and they're coming into our public health site also to get the vaccine. And that's a number that's not factored in when you look at Wayne County. I'll just mention that to you also.
I think that's a really good point. We do every week actually look at the number of vaccines that are given in Indiana, and the individuals live outside of the state of Indiana. So we look at all of our surrounding states. And we do know that there's probably about 15,000 total doses that have been given to different states, basically through our counties, right now. We have actually had several areas that had to kind of clamp down and say, you really do have to live or work in this state to be able to get it, because we were finding that there were a lot of 70 and 80-year-olds that, were coming in and getting vaccine here because other states were not prioritizing the highest risk categories or groups.
Well, I can tell you this, everybody from Ohio tells us what an outstanding job the state of Indiana is doing on the vaccination program. We hear that constantly. I was in a doctor's office yesterday, and they even mentioned that to me, what a great job you guys are doing and getting it throughout the state.
Thanks. We are great partners. I'll tell you, Dr. Weaver and her team, and then all of our partners across the state that are giving this vaccine have been incredible. And like I said, nobody's saying, hey, why do I have to do this? No, I don't want to be engaged. They're just like, we've been planning for this. We're ready. Just give me more vaccine. So we'll get it to you as quick as we can.
Again, if we get close to your hard stop, just let me know and we'll cut these off. But several of the counties received grants for testing to set up testing sites. And now that we're switching to vaccination, can they use that grant money to change that into a vaccination site, or does it have to maintain a testing site?
So what we've been doing is actually looking at, we pay for the Optum sites around the state, and we had several sites that had 3 lanes, meaning that, they had 3 lanes of people testing there, or 2 lanes. And we've been looking at those sites, and if they're not busy, what we've asked them to do is to reach out to the local health department and offer that workforce to the local health department, so that if local health department says, hey, I would rather use these people on my vaccine site, we'll bring the Optum people in for now, and they can run our testing at the local health department site. That's fine with us, because that still keeps the Optum site open so that their hours are there and available for people, but maybe it reinforces the local health department site, because we don't want to close down a lot of testing sites right now. Because as you know, we're on the downslope right now, but typically we do see an upslope, and I'm very, very worried about these variants. I mean, the covariant that we have right here, right now, the one of concern is the UK variant, and we expect by the end of March, that's going to be the #1 variant in Indiana, and it is much more transmissible, which means much more infection, hopefully to goodness, not more hospitalizations and death, because we're getting the people that are most at risk for that with the vaccinations right now, but we want those testing sites up and available. I hope that answered the question.
Yeah, I think so. Yeah, it did.
But I'm happy to work with any individual local health department that needs more workforce to see if there are Optum people that we could get to help them during this vaccination time.
So looking forward, what is the, I don't want to say exit strategy, but what numbers do we have to get to where the emergency orders will most likely go away, at least statewide? We still may have pockets in the state that operate under emergency orders, but is there a number in mind as to say, once we've hit this number of distribution of when will the order go away?
So I think it's a multifocal problem. So we're looking at not only are the numbers good for numbers of infections, which are trending and improving, the numbers of hospitalizations are down, but also, I'll be with you in just a second.
Sorry.
I'm sorry, I'll be there in just a sec. I apologize, guys. Numbers of infections down, but also number of hospitalizations and deaths are down. But then also, in addition to that, making sure that we have gotten more vaccine in arms. Really, we need to be, before we abandon anything like masks and we start saying social distancing is not important and don't worry about going to the restaurant and being in there with 100 of your favorite people in a 10-foot square area. We need to have more people vaccinated, which really is more like that 70 to 85% of people. So we're going to be working on this through the summer and into the fall. Now, whether things will change with regards to restaurants and bars and other things, that's really a discussion with the governor and his team going forward. I'm sorry, guys, I really do have to step off because they're in here shaking their finger at me. I'm sorry.
No, thank you so much. Very informative, and appreciate everything you've done for the state. Thank you.
Have a blessed day, everybody. Thank you.
Thanks.